We'll now move on to the final presentation before lunch, which will be Sue Pavord, who has spoken at these meetings before and has really led on a lot of the investigations of COVID immunisations and the problems of thrombocytopenia, has collected a lot of data on there. But I've given a relatively open remit to talk about what she feels like, so she doesn't feel trapped in talking about the same thing every time. So thank you, Sue.
No problem. Thank you ever so much, Adrian. So I'll keep an eye on the time because I know we don't want to miss our lunch. So the good news is last week, the World Health Organization issued a statement, I'm sure you've all heard, that from the Emergency Committee on the COVID-19 pandemic, that COVID-19 is no longer a public health emergency of international concern. So that is absolutely fantastic. But what do we mean by public health emergency of international concern? It's abbreviated PHEIC. It basically means that, one, it's not unexpected. Well, 3 years later, let's hope not. That there's no concern about international boundaries. So all the sort of travel restrictions have been lifted, and that it no longer requires global collaborative effort to deal with it. But there have been significantly reduced reports of cases, reduced deaths, hospital admissions, and increased pandemic fatigue, not only by us as part of the global population, but the virus itself. It's kind of learnt to, in a way, it's achieved its goal. It doesn't want to kill its host, because that's just a bit stupid of a virus. So it's now living amongst us, fairly low virulent strains, but it's in the community. So there's still recommendations that the COVID-19 vaccines need to continue. They'll be integrated into our routine vaccination programs like flu vaccines and things. Public health surveillance needs to be maintained. The health regulatory bodies will be strengthened so that we can act promptly in the event of another outbreak, either with COVID-19 or something else, to authorise vaccines and to allow access quickly to diagnostic tools and treatments. And of course, further research is ongoing. So let's look back at what we have learnt for our ITP population over the last 3 years of this pandemic. So our lockdown was in March the 23rd, 2020. Okay, so just over 3 years ago. And very quickly, in fact, 2 weeks later, we cottoned on to the fact that our usual treatments for ITP is going to be problematic, or it potentially is problematic. So we started writing some practical guidance about how we should treat new and relapsed ITP patients, trying to avoid immunosuppressants like steroids, mycophenolate, azathioprine, and rituximab, because we were concerned that if somebody contracted COVID, it's going to make it a lot more of a severe disease. And we were then very lucky to engage or secure the support from NHS England in allowing us to avoid steroids as first-line therapy for new and relapsed, and to be able to use non-immunosuppressive treatments like thrombopoietin receptor agonists up front for these patients. Now that is off-license use, and so now that it's no longer of international importance, this pandemic, of course that has sensibly been withdrawn, and we can go back to steroids first line. There were a lot of other information in this guidance that we wrote, and it's really lovely to see actually that whilst we wrote it kind of promptly and to be pragmatic, all of those recommendations have been borne out over time. So when we change treatments so drastically or dramatically, of course we need to monitor this. And so we established a prospective audit of how new and relapsed ITP patients were managed during the COVID pandemic. And this was over a 12-month period from the 1st of March 2020 to the 1st of March 2021. And it was online prospective reporting, and you can see the centres and the contributors that were involved. So overall there were 343 patients entered, and this is a very characteristic demographics of an ITP population. So median age 57, slightly more females than males, 22% with secondary ITP with backgrounds of other autoimmune disease or malignancy. Most of them were new diagnoses and a third were relapses, and the median platelet count at diagnosis was 7. So the first line therapies that were used were still predominantly steroids, and that's because many centres either hadn't made the change or didn't want to make the change. Some people like to use steroids as a sort of diagnostic tool because, as you know, we don't have a primary diagnostic test for ITP. But 47 patients had thrombopoietin receptor agonists alone up front, so didn't have any other treatment whatsoever. So it was useful to see what they did, and we found that they had an 83% treatment success. So it's really, really magic with these drugs. And what we defined as treatment success was meaning that they don't need to go on to have second line treatments. If they were given steroids up front, then they had TPO-RAs as second line. They didn't need third line treatment in 77%. And if they were given third line TPOs, they didn't need fourth line treatment in 85%. So it was really, really successful. In terms of the speed of response, you can see that steroids and IVIG had the fastest response. But nevertheless, TPOs, actually a third of them had gained platelet count over 30 within the first week, which is actually faster than we'd previously been led to believe. So that's fantastic. But a third also needed more than 2 weeks to gain that safe platelet level. Vicky's already talked about the thrombotic risk of ITP. In this patient cohort, the overall thrombotic rate was 4%. And in fact, if we look at the TPOs, it was the lowest group really, was 2.1% compared to 5.8% of patients who had received steroids. So that was really very encouraging in that, because there had been concern about the TPOs increasing the risk of thrombosis. That was not borne out by this study. Now, over the time, there has been an increase in the number of patients with ITP during this pandemic, and we're familiar with viruses potentially triggering ITP. Nearly 7% of our patients had a positive COVID test, and the interval between the day their COVID symptoms started and when the ITP was diagnosed was 12.5 days. But there was a big range, as you can see. Some people had been on maintenance therapy, and all 4 of those who'd been on mycophenolate, actually, when they got their COVID, they needed ventilation. So let's kind of move on to vaccinations now. So if you think about the time period with which we carried out this study, it was the 1st of March 2020 to the 1st of March 2021. That means that it was only the last quarter of that data collection period where we had started population rollout of the vaccine. And yet, 18% of these cases had occurred post-vaccine. And predominantly, it was 24 days post-COVID-19 vaccine. Now, there were a number of vaccine concerns that came to us at the time. Potential for ITP relapse or new presentation, which I'll come on to. The impaired immune response in those on immunosuppressants. And again, this has also been borne out because of rituximab has been shown to dampen the response to COVID-19 vaccines. So we try and separate the interval between having the vaccine and waiting, if we can, a couple of weeks before any rituximab is given. Obviously, for patients with low platelet count, we need to compress the vaccination site because it's an intramuscular vaccine and we don't want to cause an intramuscular hematoma, but we didn't really see that happening. But we did advise maintain compression for at least 2 minutes on that site. We did see quite nasty nosebleeds with those horrible PCR swabs that we all remember were really quite horrible. And for patients with ITP, it was actually causing some nosebleeds. So this is our rollout of vaccine in the UK, starting it was really the 4th of January with the AstraZeneca vaccine. Prior to that, we had Pfizer, mainly for healthcare workers, and then in the last 3 weeks of December, it was Pfizer. But the 4th of January, it was the AstraZeneca that we rolled out to the vulnerable groups, and then the elderly, and then coming down in ages. Now, you very helpfully, in the early days, gave us some data on your own platelet counts. This is patients self-reporting to the ITP Support Association database. And if you look at the Pfizer ones, most people stayed fairly steady. So you can see the pre and post counts are the same. But there were a few where the post counts were much lower, so potentially triggering a relapse here. And it's shown a bit more easily with that graph there. With the AstraZeneca vaccine, it was really interesting because nobody had the same platelet count pre and post. So it either got better or it got worse, but nobody had it the same. Now, of course, there's huge limitations to this data because it's not collected in any standardized way at all. But nevertheless, that is interesting, the difference between the AstraZeneca and the Pfizer vaccines. So there was a big population case control study in Scotland. They looked at 2.5 million people, of which 1.7 million had received the AstraZeneca vaccine and about 0.8 had received the Pfizer vaccine. And they found that actually with the Pfizer vaccine, there was no increased association with ITP. There was no increased numbers of ITP with Pfizer. With AstraZeneca, there is potentially a small increase, and it was 11 per million doses of vaccine, 11 new cases. They found that the increased risk was first seen in the second week after vaccine, but most pronounced in that 4th week after vaccine. So we kind of define vaccine-associated ITP now as within 30 days of your COVID-19 vaccine. What about relapse in ITP patients? So known ITP patients who are now having the vaccine, is it going to cause a relapse of their disease? So there have been a number of important studies here from the USA, from Canada, from Europe and the UK. The numbers have varied, and there are 3 prospective studies, and 2 retrospective ones. And of course, the relapse has been defined in different ways according to the study, but nevertheless, it looks like it's kind of between 5 and 15%. And the time to relapse, well, it's largely within 28 days. But if you look here, the response to treatment, most studies found that actually it's really easy to treat these patients. So either they don't need treatment at all, or they just respond in the normal way, like all ITP patients needing treatment. The only outlier there was the UCLH study, which found that 24% remained unresponsive at 34 weeks. But that was an outlier and hasn't really been borne out by other studies. So this Canadian study actually compared patients and healthy controls and found that both ITP patients and healthy controls on average dropped their platelet count by 6%. So there was no real difference there. But nevertheless, there were some relapses in known ITP patients. It was ITP exacerbation in almost 14% of patients, and they did look at the risk factors for that, and interesting found it to be younger age, which other studies haven't shown, people on current ITP patient, and those with a baseline count of less than 50. So Quentin Hill and a group of us have produced this guidance from the UK ITP Forum Working Party on relapse following vaccine. But Quentin is leading, Vicky's already mentioned it, on a very important data analysis going on at the moment of what has been the effect of vaccines in for relapsing disease and on re-challenge for a booster dose when you've already relapsed with the first vaccine. But this is our guidance at the moment. So a diagnosis of COVID vaccine-associated ITP can be considered within 30 days of thrombosis. We need to absolutely rule out another cause of that thrombocytopenia occurring after vaccine. And of course, my pet subject is vaccine-induced thrombocytopenia and thrombosis, which was a completely different condition. And patients with ITP don't appear to be more at risk of it. Much more serious condition, that one. If there is COVID-19 vaccine-associated ITP, we can treat it along standard lines of treatment, and people do very well. They can, and we do recommend that they engage with the vaccination programme as advised, but being aware of the potential risk of relapse. And we recommend that patients have their platelet count monitored at 2 to 5 days following vaccine. Most of my patients actually don't want to, and that's also fine. And although the risk of further ITP relapse appears higher, we do again recommend that re-challenge of the vaccine, that booster doses are given, but we are analysing that data, and so more to come. Watch that space. Just in the last 1 minute, really, we are very mindful of the burden of ITP for you. And Nikki Cooper led on this wonderful study a few years ago now with questionnaire basis over 13 countries. And really, COVID absolutely added to this anxiety. We know the effects now of anxiety on fatigue, on the symptom burden of ITP. And COVID really added to this. I mean, it was terrible, not least all the changing guidelines about who should shield, and then introducing new concepts like levels and clinically extremely vulnerable groups and things like this. It was really confusing. So we did try to provide support for patients. Cindy's already talked about the joint decision-making toolkit. And we ran Zoom and Teams meetings, both locally, regionally, nationally, to try and support patients, and provided some patient information about COVID on the BSH website. So if there's any other major outbreaks, we will be able to restart those procedures, but do keep us posted if you need more of those. Just to reassure you, you are eligible for COVID-directed therapy should you be admitted with COVID infection, because you fall into the category of acquired conditions affecting the immune system. So here are my conclusions. It does appear to be more common during the COVID-19 pandemic. Management of new and relapse cases needs careful consideration according to the status of the pandemic at the time. It was fantastic that we had a short spell or 2.5 years really of using upfront TPOs, because we were able to see what excellent response there was. And so that has helped pave the way for more research, and hopefully they will get their licenses for use of upfront treatment. There doesn't appear to be evidence of de novo ITP with the mRNA vaccines like Pfizer and Moderna. A slight increase with the adenoviral vector vaccines like the AstraZeneca one. And COVID-19 vaccine may potentially increase the risk of ITP relapse, and again on re-challenge. But with Quentin's data, we will know more about that soon. Thank you.
I think we could certainly take 1 or 2 questions here because we're only delaying lunch. So maybe put your hands up. Vicky, there's a question here, and then there's one over there, and Mark.
Actually, it was more a comment. Firstly, to say thank you to Sue. And actually, she was brilliant in leading a lot of this learning during the pandemic. So we're very, very grateful. But just to add that the registry data around COVID-19 treatment, I didn't touch on it because I didn't want to muddy the waters, and Sue had her own special COVID talk, but it shows a similar, that early TPO RAs, there's about another 450 within the registry over a 3-year period, shows exactly that really excellent response rates early on. In the registry, most actually had steroids with them. There's not so many without for those that have been entered. So I think it very much supports what you're saying, that, and no thromboses reported from the sites to date.
Thank you. There are a couple over there. Just while Mervyn's wandering over the microphone, I know you haven't got the full data yet, but do you have a feel for what happens post the second challenge?
Yes, I think the risk appears to be slightly higher. I think, Quentin, you might want to comment here, but it's sort of 5 to 15% after the first, slightly higher on re-challenge. But if you can give the microphone to Quentin Hill, because he's got inside information.
So yeah, well, I think it's probably in the final analysis going to be less worrisome than we originally thought, actually. So I would the steer might be that if you are having a relapse with a COVID vaccine, well, it's personal choice, of course, but I think the steer is going to be your risk is probably not highly elevated if you have a further COVID vaccine. So yeah.
And does that depend on type of vaccine?
Because of the way it transitions, most of them were on Pfizer by then, so there's probably not enough granularity to say with confidence. There wasn't a clear steer. It didn't appear to matter usually.
Thank you.
Yeah, I was wondering, do you think that, don't you think that the low risk of relapse or flare of ITP after vaccination should be counterbalanced by the risk, which is pretty similar, of relapse or flare of the disease with COVID-19 infection? And so what we did in France, what we did recommend during the pandemic, basically, is that for a patient, let's say age over 50 or younger, but with common risk factor of severe COVID, the risk over benefit to vaccination was favorable. Whereas if we were facing a young lady, 20 years old, with no comorbidities, severe ITP, we tended not to vaccinate her because the risk of developing severe COVID and ending up in ICU was close to zero. Could you comment on that?
I can comment on that. Sure. David, was it in response to that, David, or different? Okay. Okay, that's a very good point, and of course we saw that a bit with VIT, with the vaccine-induced thrombocytopenia and thrombosis, much more serious condition, that it was affecting almost the people who weren't going to be those dying of COVID. They were younger and they were previously fit and well. But nevertheless, even with those, we have not gone down that route to say don't bother getting vaccinated because we are worried about spread of disease. And so on a public health basis, we still do encourage vaccination.
There was one in the third row, and then David.
Yeah, just to continue on that theme, and you looked at the effect of the vaccine potentially making ITP worse, with my wife, who had a bad reaction to the first AstraZeneca vaccine. When she sorted herself out from that and had a blood test, we discovered that the platelet count had shot up. So since then, she's been having the Pfizer vaccine, and every time the platelet count goes up. So we now have a new treatment for ITP, which is COVID vaccine, and it's free and available every 6 months. So.
Excellent. Very good.
I have my vaccination, and it doubled my platelets, but it only lasts for about the 6 months. Yeah. So I just like the COVID vaccination. Yeah, but I don't know if other people have found this, but it is an easy way forward.
Yeah. Well, I did show that on the, certainly with the AstraZeneca one, on those initial patient-reported graphs, that half of the patients had actually increased their platelet count.
It was certainly something that came through from the data we were collecting post-vaccine that the association got. Yeah. I can't remember the exact figures. David.
I'll make this really quick. ITP patients get vaccinations for other disorders, shingles, influenza. Does thrombocytopenia present a risk for those vaccinations? I have a number of patients, every time they get their asplenia vaccinations, they crash their platelet counts in a similar fashion.
Yeah, I mean, that's a very good question, because it's not only the COVID-19 vaccinations that we're thinking about. Of course, they're all new to us over the last 2 years. But even prior to that, people were looking at the effects of flu vaccines, of MMR and things like that. And I think it's very difficult to answer that. We've had the benefit in a way with COVID-19 is the sheer volume, the numbers of patients that we've been able to learn from. So thank you.
Thank you very much, Sue, for a fabulous presentation and for the questions.